Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Linda Hurley, President and CEO of CODAC Behavioral Healthcare.
I am the President and CEO of CODAC Behavioral Healthcare, and we are the largest, oldest, and only nonprofit provider of behavioral health care in Rhode Island, with a specialty in the treatment of opioid use disorder.
How did CODAC Behavioral Healthcare get involved with the Rhode Island Department of Corrections?
There's a very cool synergy in Rhode Island. You know, we're small, we're the size of a peanut, shaped like a peanut, the old joke. But CODAC Behavioral Healthcare started recognizing the relationship between substance use disorder and behaviors that would connect individuals to corrections and justice systems. We have a history of collaboration. It's actually part of our mission is to enhance services through collaboration and enhancing existing opportunities. So at the same time that was the development of CODAC, we were in a state where our correctional department was also one of the more progressive relative to rehabilitation. So as far back as the 70s, CODAC was providing parenting programs for the women's prison, providing DWI trainings for those that had multiple DWIs and were hence incarcerated. So the relationship went back pretty far. 1994, we started using a courier to take the medication from our dispensaries in our OTP program into the prison for pregnant inmates. And from that point, our relationship developed. And again, I have to speak to the remarkably progressive philosophy and foundation of Rhode Island Department of Corrections. So between 1994 and 2002, we started increasing the populations for whom the medication would be delivered and provided, and the treatment associated with it, counseling and discharge planning, etc. So we went from having methadone to one population to having it for a number of populations. And in 2002, with the advent of buprenorphine being available, we started to introduce buprenorphine. From 2002 to 2014, whenever, frankly, there were dollars, we would expand the populations for whom we could provide this service, working very, very closely with the medical department at the Rhode Island Department of Corrections. In 2014, Dr. Jennifer Clark, who at this point everyone is aware of, we had the honor of partnering with her to create the Enhanced Medication-Assisted Treatment Program, as it was called then. And that's the history. And I think one of the takeaways from that is that much of what we're doing right now, when we're really turning a system on its head a bit, there's a lot of culture change in providing this particular medication and comprehensive treatment within the institutions of corrections, that relationship is so critical. Relationship is so critical. And for any systems growth, any systems change, there needs to be the nurturing of relationships that then create transparency and trust. And that's how we move this forward. And I believe that we were fortunate enough to have an extended period of time in order to develop that. because in 2014 is when the model really got to be enabled. And I have one slide that I often use when I'm presenting on this, and it shows parallel process across the board so that it's collaboration on a state level, and then collaboration between state agencies. And at the same time that we have these horizontal parallel collaborations happening with providers and then with recipients of care, it also becomes vertical. And that is a very strong foundation for systems change like this.
Will states without a progressive Department of Corrections be able to follow a model like that in Rhode Island?
Basically, the model itself is very simple. There's sound medical principles that we know this is a chronic relapsing disease of the brain, according to 2018 or 17 AMA. Chronic relapsing disease of the brain. What do we do for it? We provide behavioral health care, counseling, psychosocial interventions. We provide the medicine when it's indicated. And just like with any other disease, we provide education so that lifestyles can be created to support what's healthy. So it doesn't have to be statewide. It can be countywide. It can be townwide. It could be a jail with 6 people with opioid dependence. We presented yesterday a panel that showed 4 different models. And one of those was a smaller county in Massachusetts. And they don't have a large number, but they honor that they're individuals that have this disease. And they actually take those 4 or 6 people out to an opioid treatment center to get their medicine and bring them back. So that's small. It's small and it works. Or you can have a system that has, 22,000 people in it, and you break it into smaller units. It can be done. You follow the principles. The operations themselves are just going to reflect the logistics of that area. And then there's a panel discussion right now on systems change, how you get buy-in. And that's there's workbooks everywhere. This is what you have to do: relationships, trust.
What role does CODAC Behavioral Health play in the continuation of treatment at reentry?
An enhanced MAT program means that, or a treatment program utilizing MOUD, means that all FDA medications for this disease are available. At this point, it's 3 in different formulations to anyone coming in or already incarcerated that needs it. Okay. And along with the behavioral health care components. That's it. All that efficient, effective care is not going to have the results we need, not just want, but need, if there isn't an overused word, but an important one: seamless transition into aftercare upon reentry. So what we do in Rhode Island, CODAC is fortunate enough to have, I believe we now have 8 sites in Rhode Island. And one of our deliverables to the Department of Corrections is that we simply, when the individual leaves, a lot of time we provide the opportunity for transportation through some other grant projects, and someone gets to their treatment the very next day, and that's what needs to happen. Now, the 9 sites, there's lots more towns and cities in Rhode Island than 9, excuse me. So what we will do is say, we bring you in, and then we help facilitate getting you to the provider or the community of your choice. That's critical. And the wraparound services are then critical, because over and over we hear that what is most important when people get out is they need a place to live, and they would love to have a job that matters. Not just a job, but a career path that reflects my sense of value. So it's a full continuum, but the reentry component is part of an enhanced MAT, because if you're just looking at what's inside, there's no way to sustain it, and you're looking at the most vulnerable population without supports.
Since the peak of the opioid crisis, Have you seen a change in the number of individuals you serve?
We continue to see a slow increase. What does that mean? It could be availability of the product. It could be that more and more treatment is available, so more and more people with an existing disorder are seeking treatment. We really don't know, but we are not seeing a decrease yet. In terms of overdose death, we are definitely, in this particular population, we have seen a significant death. Back in 2015, the Governor's Intervention and Overdose Prevention Task Force recognized the population of those that had recently been incarcerated as the most at-risk population in the state. 24% of the deaths in 2015, I believe, 25% were people that had been recently incarcerated. So we know that overdose death is 127 times more likely for someone that's just left the prison than average population. So we know it's a very vulnerable, very high-risk population. And although the numbers, weren't in the hundreds, we certainly saw a decrease within 1 year of the provision of this in overdose death, which not only, actually, I think I've seen it quoted as to 61 and 65% decrease in overdose death in this population upon reentry. That's astounding. That's life, and that then also impacts in many ways the overall state decrease, not just numerically, but there are fewer people buying and selling, fewer families impacted by, mom, dad, daughter, son, leaving prison and resuming, the activities associated with their disease.
Do you think that individuals see the success of their peers as inspiration to seek treatment?
It could very well be. I mean, there's so many variables. I spent a great deal of time recently with some researchers and people who do data analytics, and I just kept coming back to that. All I have for you is anecdotal. We have some numbers. I know how the increase in folks coming into care. I see the differences in substances, uptick in fentanyl, nothing new. But it's absolutely, it's that soft relationship community piece that's changing, and even when you look at not just the public health issues of the opioid epidemic, but the associated uptick we're seeing in hepatitis C and HIV, we know that the folks that are actively involved in supporting their disease are the primary transmitters in our community. So when they heal, and they start to heal from the disease and they're no longer utilizing or engaging in behaviors that result in transmission of these infectious diseases, the ripple effect is just amazing.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.